Let's try this again.
Oh, we got it.
Oh my God. Oh my God. What was that?
I'm pretty much an old guy at this point, so.
That's how I feel these days. Like, am I old? Why can't I figure this tech stuff?
I
Hi,
don't
Sal.
program life.
How are you?
Good. Thanks for having me on.
I'm so glad this worked. I was like, are we going to have to reschedule? What's going on? Go ahead. Say it again.
I was getting nervous too. I was like, oh man, we're going to have to reschedule this thing.
I know. You know what I had to do? I had to uninstall the app and reinstall it.
Yeah, I updated mine too in the meanwhile.
Oh, good. Good. That works then.
I had to go down to escape my kids. They're having a little meltdown, so.
Oh, really?
Yeah, we're trying to get stuff ready here, and so what they do.
We'll be happy to have them join the live.
Oh, okay.
It'll be good to see JoJo. Victory, yes, yes, I know. Guys, Instagram has shown me its true colors. All right, we're ready to get started. Welcome to Uncommon Knowledge. I'm Dr. Drew White. I have Dr. Salvatore Catarinicchia.
Man.
Did I say that right?
That's always step one in a visit is going about, having about a 5-minute conversation about my name.
Do people just call you Dr. Sal or?
Yeah, just keep it easy.
Easy? Okay, Dr. Sal it is. I saw that your brother joined. How cool is that? Alessio.
Yeah.
How cool is that?
There.
Say it again.
That's my baby brother.
Awesome. It's good to have everyone. So I'm going to do a little introduction of Dr. Sal. Dr. Sal is a native of Minonk, Illinois. That's like central Illinois, right? Yep. Central Illinois. I remember we used to go to Minonk to your dad's pizzeria to have some authentic Italian pizza. Mm-hmm. Those were good times.
Oh, yeah, the best.
Dr. Sal graduated from University of Illinois at Urbana-Champaign. And then he got his medical degree at the University of Illinois in Rockford in 2013. That's where I met Dr. Sal. And he completed his general surgery internship and urology residency at the University of Colorado. Dr. Sal works at St. Joseph's Hospital in Bloomington, Advocate Bruman in Normal, and St. James Hospital in Pontiac. Oh, I used to work at Pontiac too. When I saw that, I was like, oh, cool. Dr. Sal's interests are robotic prostate and kidney surgery. So he does a lot of, robotic surgery, minimally invasive surgery for the prostate and for the kidneys. Urethral reconstruction. So where you pee from, he kind of reconstructs it if you're having some issues. Kidney stones disease and voiding dysfunction. So like if you're having trouble peeing, he can help with that. He has a great love for Central Illinois, which is why he moved back home to provide that expert care for his people that he loves in Central Illinois. I'm super excited that you took me up on my offer to join me today, and I'm excited about what we're going to talk about. Did I miss anything? You want to add anything?
Nope, you got it. You got it. Yeah. Those good old days in Rockford, baby. That was awesome. But
yep.
Dad's still around running the pizza place, and we wanted to be closer to home here and take care of, the people that grow up with, That's what we do.
Yeah. Oh, that's awesome. That's awesome. So the pizzeria is still running. Do you guys still go home often?
We were just there like 2 times.
Oh, sweet. Sweet. That's awesome. All right. So I'm going to leave the floor to you, but I wanted to see what you thought about this. I was thinking we would start with what testosterone does in the body. What parts of the body does testosterone affect? Yeah,
that testosterone stuff in general is probably one of the most common things that I see in my clinic on a day-to-day basis. Most general urologists will manage testosterone and things of that nature. But testosterone's function is basically, the way I think about it, is the fuel for the guy. It has a little bit to do with everything in the male body and also in females too, but to a lesser extent.
Mm-hmm. So you would say, like, for metabolism, like your weight issues, for your brain function, for even obviously your sexual health, you would say testosterone has effects on all those guys.
Everything, yeah. So, one of the things that we'll often talk to patients about regarding testosterone replacement is that you know, there's a lot of sensationalized media regarding testosterone replacement. Let's say it that way. But for some guys, it just helps them think better. They may not necessarily be able to, you know, put on a ton of muscle after working out or recover or have improved sexual function, but they just say, I feel overall like I can mentate better, I can think better, my mood is a bit more stable. So on that front, it can have those kinds of effects. But it does affect pretty much everything. Yeah, metabolism is a great one too. It helps guys recover more quickly after working out or just their day-to-day life and job.
That's so interesting because that's the same conversation I have with women about estrogen. Estrogen affects, you know, when they start losing estrogen, the first thing they tell me is their memory, you know, memory function. Is that one of the kids? Oh, Angela. You know, it affects, you know, their mood. It affects their ability to concentrate, you know. Obviously, there are other hormones involved in the process, but the dominant ones that we know for women is estrogen, and the dominant one we know for men is testosterone. So around what age do men begin to lose testosterone? Like, when should they start thinking about, you know?
That's another great question, and it's quite variable. So in some guys, I've replaced testosterone in 30-year-olds. You know, it's one of these things that if you are feeling symptoms and the laboratory exams back up your symptoms, you're a candidate for replacement. And as opposed to women who have kind of a general, you know, kind of carved out time in their life that they can expect to go through a menopause, guys have a very gradual andropause, is kind of what we call it, how we think about it, where their testosterone level starts to definitely go down, but at a much slower rate and over a longer period of time, as opposed to the women. But, you know, as early as your 30s, you can start to feel symptoms of this, especially if you live a very stressful life, you have a hard job, you know, anything can kind of contribute to that. But most guys that we're seeing coming in for testosterone replacement are starting to be in mostly their 40s, 50s, and into their 60s.
Any particular thing that you notice among the 30-year-olds that contributes to their loss of testosterone? I know you said stressful life, stressful job. Yeah. Any other medical issues that might be causing the loss of testosterone in their 30s? Yeah.
I mean, there's a lot of different things. There's different medications that you may be on. Some guys with chronic pain from injuries earlier in life, you know, that chronic opioid use or pain med use can sometimes suppress the testosterone production. In general, if you've lived a somewhat unhealthy life up into your 30s, you will start to notice that your testosterone level is going to be a little lower, especially if you're carrying around a little bit of extra weight. In fact, there is some medical reason for why that is. If you have, you know, the old donut around the belly, like all us guys start to get in our 30s, as that kind of grows, you have enzymes in there, aromatase, and that's going to convert your testosterone over to estrogen. So that stress in general, inflammation in general, you know, the body is not going to be pumping out, you know, good, useful testosterone if it's kind of in this chronic state of stress and anxiety. All of the hormones definitely have an interplay with one another, and that can lead to a decreased testosterone production. So it's a little bit of kind of what you're doing in your life and what your body is able to kind of do and keep up with. It's a combination, you know, kind of medicine, as you know. But I tell this to patients all the time, you know, a combination of genetics and environment. We talk a lot about that with cancer, but it holds true for testosterone and kind of overall vitality as well.
That's so interesting. So that one about, you know, mid-belly fat converting your testosterone to estrogen is, you know, it's a bit of a revelation for me, because I always thought that happened in some parts of the body, but not because you were gaining more weight around your belly area. Yeah,
central adiposity, I mean, in general, this is not something that I talk a ton about in my clinic, but it's something that I do touch on from time to time. You know, an endocrinologist or a primary care doctor probably talks a little bit about that, but that central adiposity, meaning just kind of that belly fat, has so many health implications, cancers, testosterone, all of it,
Yeah, diabetes, right. You had said that if someone had lived an unhealthy life up until their mid-30s, meaning just eating anything, not exercising, that would add to the weight gain. That would, you know, make them lose their testosterone earlier. That's
Yep.
That's important for people to know.
Also, like, as we're going through life, 30s is a very common time for men and women, but, in general, all of us to start our families, take off careers. It doesn't matter what career you're doing. And that tends to be a period of, a lot of stress, a lot of change, where you're focused on a lot of external things, right? You aren't as focused on yourself. And there are some studies to show that if you have kids, your testosterone goes down as a guy. And there's a couple of reasons why we think that is. For one, it's to help you tolerate their screaming in the middle of the night. Walking around with a testosterone of 1,000, which is very high, you're probably not going to be able to tolerate that scream from your newborn in the middle of the night. And that's one thing that we've seen in studies kind of bear out that, as we have kids, as we kind of, are focused on work and, having that stress, your testosterone kind of naturally drops kind of to help keep the mood stable.
That's so fascinating. So you're saying that if someone has a testosterone of 1,000 and a baby screaming, he might be a little bit more aggressive towards the baby.
Yeah, kind of got to think about this in evolutionary perspectives, right? Back, we're walking around as cavemen. If you're a hunter and gatherer and you're always trying to go kill something, you got to be able to tolerate the scream of a baby. So that's kind of what we think.
That's a great analogy. That's amazing. And we had talked about how that central fat around your belly can lead to medical conditions that then lead to, reduction of your testosterone. Not just that, but the actual excess fat.
Yeah.
Because the testosterone converting to estrogen happens in the fat cells. So if there's more fat cells, more action on the testosterone is going on. Am I getting that correlation right?
You are, which is good news too, in a sense, because if you do have that and you have a very, not let's say easy, but a non-medical way to boost testosterone, right? So if you to kind of watch what you're eating a little bit, just incorporate a little bit of exercise into your weekly, routine, even a little bit goes a tremendous way in boosting the testosterone naturally. So when I see guys who come in and they are younger, maybe 30s into their 40s, that's the first thing we always talk about are lifestyle changes. In fact, in most of my guidelines, no matter what I'm treating from the American Urologic Association, it always starts with lifestyle modification. I'm sure an OB-GYN as well. Right. But I've seen guys, we've had the conversation about, hey, I'm here for testosterone replacement. I'm like, why don't you go do this for 8 weeks? See me back in 8 weeks and let's recheck your testosterone. We'll see 200-300 point jumps. Wow. Guys who have lost some weight, watching what they're eating, exercising a bit, the body's pretty remarkable on that front.
Which is why women get a little frustrated with men, because doing that for women doesn't equal the same thing.
Nope, not at all.
And then they drop the weight so easily. That's what's so frustrating.
Yeah, I think, us guys, it's one of the advantages that we have. There's the body, the male body, it's pretty remarkable on that front. It's always designed, again, when I think about modern medicine and science, the thing that kind of helps me make it make sense to me is going back to that primordial evolution caveman. Like, if this guy is going from winter to summer and trying to go, kill whatever, a tribe, then, he's got to be able to, get his testosterone up, put that winter weight, get it off, and become a lean attacking machine. And if you in that perspective, guys are just genetically primed for that, kind of what it is.
I mean, that's an amazing, simple, non-costly solution to boost your testosterone. And then the testosterone replacement, is it in form, what are the forms it comes in? Is it injections? Is it pills? What is your most favorite option for men?
Yeah. So a couple of things on that. When somebody comes in and they have documented low testosterone, if you were to see your doctor about this, don't get too mad if they ask for another check. That's the thing. Sometimes it depends on the time of day. All right. So you may feel tired in the afternoon, and that's normal. Your testosterone goes through a couple of, we call it diurnal variations. In the morning is when it's the highest. In the afternoon, it's going to take a little kind of slide down. It's going to peak again late afternoon when you're sleeping. And so you might have to have 2 checks before you start on replacement. Once you have that confirmed and we've ruled out other possible causes for low testosterone. Sometimes there's pituitary tumors. Sometimes there's other things. We'll usually try and rule those things out when you come to see a urologist. And we've confirmed that you have a true diagnosis of what we call testicular hypofunction, or basically we know that your testicle is not producing enough testosterone. Then we have a discussion about options. And there are a lot of different ways to replace testosterone, a lot. My usual regimen will be to try an injection of testosterone in the clinic. It's an intramuscular injection. It's a depot injection. It's released slowly over time. But that's probably my favorite way to do it to start. But in general, there are a lot of different formulations, such as the injections. You have gels that you can rub kind of on the chest or under the armpit. A lot of guys will do that. There are patches that exist. You can do a subcutaneous injection, so once a week injection into the belly fat, not the muscle, but into the fat. My other favorite way to replace it is testa pellets, so little pellets that are full of testosterone that we can implant, make an incision right on the upper butt cheek, put anywhere from 6 to 14 of those pellets in, and those are a nice
Wait, what is the dose of that pellet that you would inject 14? What doses do they come in?
Yeah, it's a little bit variable depending on if you get brand name Testapel versus compounded. They can have 5 milligrams up to 150. I mean, it's totally variable. It's a big dose, but you have to remember that these are not all releasing drug at one time. These are a slow kind of leaching of drug, into the surrounding tissue and then into the bloodstream. And the reason I like it is because it can last, most guys will go 5 to 6 months before needing a repeat. Yeah.
You know what's fascinating about that is that I started doing testosterone replacement for women.
Yeah.
I started just a few months ago.
And for women, they might just need one pellet is all you need.
Yeah, that's why I freaked out at 14. It's like, because I'm only doing one pellet for women.
Yeah, but in guys, it will boost. If I was to check a testosterone at that first, couple of weeks, it's going to be sky high. But the idea is it's a nice kind of smooth delivery into the therapeutic window, and then a nice smooth metabolism of the drug on the back end. One of the biggest issues that I see, especially with non-urologist replacers, is when you are given testosterone and you have little instruction and education, the patient that is, of how this is actually working, okay? Go to a peak level, your body's going to metabolize it, and then it's going to go down. And depending on how quickly the body metabolizes that, you might be feeling like crap even though you're on replacement. Have mood swings, anger issues, you can develop acne. There's all sorts of different things you got to be on the lookout for. So a lot of people will have their testosterone replaced but not monitored appropriately, and that is another that I see sometimes as well.
That's really remarkable. So I like how you said that you confirm at first that there is an organic deficiency in testosterone, meaning it's not a medical reason that their testosterone is low. It's not because of some meds they're taking that their testosterone is low. It's because the testes is not making testosterone. Then that person is a good candidate for testosterone replacement. And like you said, the gradual release into the body, and then obviously your body's going to burn it off. You're using it as you go about your day to day. And the fact that it can last up to 6 months, I think the convenience will be amazing for people, so that they're not at the doctor every month for an injection.
Right.
Maybe twice a year.
There's a lot of caveats to all that. These turn into several visits and fairly long discussions at first until we kind of figure out. There's a lot of insurance issues with test the pellet replacement. I would say actually a vast majority of the guys that I treat are doing either they come into the clinic for every 2-week injection into the muscle, or transition those injections to the home. And there they'll do it a little bit more often at a lower dose, so twice a week at a lower dose. But one thing that I think needs to be made clear regarding testosterone replacement. So a lot of guys will say, look, I have really poor, and this is probably the more common, middle-aged guy. I have really poor, libido. I have no energy, and my erections are suffering. I think I have low T. which is a reasonable thing. Those are all symptoms of low testosterone. But I think a lot of people think that, you know, a shot of testosterone or testosterone replacement is going to fix all of that. And one thing that needs to be made absolutely clear is that it may not. In fact, the thing that it helps with the most is that general sense of vitality, that kind of mental clarity, kind of getting the fog, you know, out of the brain. It helps with that. It might help a bit more with recovery, with your day-to-day life. You know, if you work a hectic job, whether it's a desk job or a physical job, whether if it's stressful and hectic, it helps a lot on those fronts. In fact, the thing I see it help the least with is probably sexual function.
Oh, wow.
But that being said, I've treated plenty of guys who've had remarkable, you know, improvements on those fronts as well, and have been able to get off of, you know, like a Viagra or a Cialis or whatever. But it needs to be made clear that it may not help on all of those things you think it's going to help you with. But I gauge success at, well, do you feel better? If the answer is yes, then I would continue on it. But if a guy sees absolutely no improvement on any front after a short kind of trial on the therapy, we'll usually recommend getting off because there are side effects for sure.
That's remarkable. And in some people, you said at first that you would have them do the lifestyle changes first.
Yeah.
And if those make the difference in their symptoms, then they don't need to be on medication. But if there's no change, then they meet criteria for starting testosterone replacement.
Yeah, the way I kind of think of it is symptoms kind of dictate the need for therapy, or if they want to have therapy. The lab value kind of helps us confirm that they're eligible for it, and it helps us monitor therapy. So there are two kind of things that kind of go hand in hand, but like a lot of the things that we treat in urology, it's a lot of quality of life stuff. Their symptoms dictate treatment. You know, if a guy has a testosterone of 200 or 150, and which is low, but they have no symptoms, and it was just, let's say, a random check as a battery of labs, we're not going to replace that. You know, he wants to. There are some other considerations there that we can talk about, but it's a symptoms-driven thing.
Awesome. Thank you for that. You actually answered 1, 2, 3, 4, 5 of the questions on my list from just that conversation.
Good.
I had a random question come up yesterday. Can sexually transmitted infections cause infertility in men?
I get this question a lot, actually. There's kind of an indirect answer to that. Probably is the best answer. It depends on what infection you had. It depends on where in the urine or in the reproductive tract a pathology was created, and I'll explain what that means. So if, for example, a patient were to have an STI that led to urethral stricture, so basically the P tube has a scar, and they are having issues with urination, they're also going to have issues with ejaculation. So it might lead to a little bit of retrograde ejaculation, which, you know, the sperm going backwards, not forward. If there's some scarring along one of the ejaculatory ducts, which, albeit this would be pretty rare, I must admit, but if there were to be some scarring along there, you may also have an issue with not getting the semen and the sperm, you know, to where it needs to go. That's all kind of a mechanical obstruction. I think that's probably going to be the most common reason why you would have issues with infertility after an STI. That being said, there are also issues with scarring within the testicle. I've seen chlamydia cause pretty bad changes on ultrasonography, on sonogram, in the testicle itself. And that can lead to some scarring within the testicle. And that basically is where the molecular machinery lives for, you know, the sperm production. So I could see that theoretically also causing issues. But in general, I think most guys are probably going to be okay if they had, you know, kind of a quote unquote run of the mill STI, and later on wanted to have kids, I think they'll be fine.
So they can just they will usually have symptoms, they will usually get treated, unlike women who may not have symptoms, and that could then lead to infertility in women. Most
guys are going to have symptoms because of probably, and this is just kind of my thought, the length of the urethra is so variable it's so different, right? Between men and women, not variable, it is different. You got 2.5, 3 centimeters versus 18 to 20 centimeters of urethra. And so there's a lot more surface area for irritation to occur within the urinary tract from an STD. So a lot of the times, and truthfully, I don't see a ton of STDs. I feel like a lot of them are treated by the ER or primary care. But the ones I do see, most of the symptoms tend to be a urethritis, an inflammation of the urethra, and discharge, whether that's clear or a little bit of pus can come out. But that generalized irritation of the urethra tends to be the symptom that kind of lets us know that there might be an STD present.
That's remarkable. So before we move completely away from the testosterone part, because I want to go to prostate. I know that that's your area of expertise. The testosterone, for those who are joining us, just joining us, testosterone is needed for everything in the male body, just like estrogen is. It affects ability to concentrate. Your testosterone starts going low if you are not living a healthy life. So if you start gaining weight, fat around the belly, your testosterone starts going low. And as you get older, it's a gradual decrease for men as well. So generally, living a healthy life, a little bit of exercise, a little bit of eating right can boost your testosterone without any medications. But if they find that that's not working, then there's testosterone replacement. Well, what about supplements? Those supplements that they do commercials for online.
Yeah.
Do those work?
I feel like it's hard to tell because obviously we don't have a ton of, randomized trials, on these generally widely available over-the-counter supplements. From what I've been able to gather just in talking to patients who have purchased them and have used them, a lot of these are designed to be kind of metabolites that the body will then use to turn it into testosterone at the level of the adrenal gland, at the level of the testicle. A lot of these are not necessarily direct testosterone replacement supplements. It's like a nutritional supplement that the body can take up to help create more testosterone. And that's kind of the idea behind it. But all of them are kind of marketed as testosterone replacement, which they're not. The only way to replace testosterone is testosterone, which is a controlled substance, right? Metabolites and nutritional supplements to kind of help the body produce more testosterone.
Would you say that they work?
I don't know. I mean, I've seen guys who swear by it, but I also think a lot of it's placebo, right? If you are engaged enough to go get a testosterone supplement, you're probably doing some other things kind of, unconsciously to help boost your testosterone, right? So if you're taking it because you want to, do a better job in the gym and work out harder, well, you're just working out harder. So more testosterone. I don't know. I don't really have enough information to tell you if they're or not. But a lot of guys swear by them. So, and I say, if it's not harming you, your other blood counts are okay, whatever,
Go for it.
Month on it, it's up to you.
So prostate, when should men start getting concerned about prostate issues?
Yeah. There's a time point in our life when a lot of guys in general should start actually thinking about this. And there are some caveats. So in a general population of guys, 55 is kind of the age that we'll start screening for just prostate cancers. At least that's what we should be doing per our guidelines. That being said, ton of controversy around this right now. And this goes back to an issue that came up in 2012. The United States Preventative Task Force, who makes like all the recommendations for, when to get your colonoscopy, when to get your lipids checked, all that stuff. They actually gave PSA, which is the blood test to screen for prostate cancer. They gave it like a failing grade, basically. So primary care doctors got super confused about this. And we're starting to see and are currently seeing a lot of the repercussions of that decision. In fact, so much so that the Preventative Task Force went back and reassigned a more favorable grade to the blood test, the prostate-specific antigen screening test. But in general, the conversation should at least be had around age 55. That's a little different for guys with a family history. If you are somebody who has a strong family history of prostate cancer, and not even on the guy's side, I mean, you can have ovarian, breast, colon, if there's a strong family history of cancers in general, then a conversation should at least be had between the patient and their primary doctor, the patient and their urologist, whoever, about starting to screen a little bit sooner for prostate cancer. And that can be as early as 45, 50. It kind of depends on the situation. And those are first degree relatives that I'm mostly concerned about. If you've got a great grandpa that had prostate cancer and no one else has, then I'm not too concerned about that. But if you're telling me my dad had it, my brother had it, or my dad had prostate, my mom had ovarian, and her sister had breast, I'm getting really nervous about you. And you might be 40, 45 years old and start checking a PSA. But ironically, a lot of the prostate discussions and prostate screening happens at the primary care level. Very rarely does somebody come to a urologist without having had any of this specifically for prostate cancer screening. I do see patients who do come for that exclusively, but the vast majority of the prostate cancers that I treat were the PSA, the initial PSA, the blood test was checked by their primary doctor. So a lot of this is happening at the primary care level. So it is actually really important for guys to kind of know a little bit about this, because going back to those guidelines in 2012, and the way that the guidelines are written now, it should be a shared decision-making discussion between patient and provider. There's a lot of gray area about who should be triggering this conversation. And urology obviously will bring it up a lot of the time because that's just what we see. But if a primary care doctor is still kind of attached to that 2012 recommendation or has a personal bias towards not wanting to offer the screening, the patient may not ever have a PSA screen. And so a little bit needs to be, us doing a better job at educating the public, like, on the female side, OB-GYNs and primary care doctors have done a great job with breast cancer screening, right? We need to be at that level with prostate screening. We're just not. We're just not. Mostly because it's a guy thing, right? We're just too machismo about it, but it's a super important thing. So I would encourage guys to start thinking, at least starting to think about it in their 40s, knowing that as they kind of get into their 50s, that's probably the time when they should bring it up to their primary care doctor. And if the primary care doctor has any kind of reservation about it, then I strongly encourage patients to come in and see a urologist just to have the discussion. It's a discussion we have a million times a day. It's a very quick discussion. Most of us have a kind of a 5-minute, summary of, the pros and cons of screening and why you should do it, why you shouldn't do it, when you should do it. But it is something I think all guys need to be cognizant of. In particular, in the African-American community, there's a little bit of higher rate of prostate cancer in the African-American community as well. So in general, that's another population that will sometimes screen a bit earlier. Instead of waiting until 55, sometimes we'll screen at 50, just because they are genetically at a bit higher risk for prostate cancer. So those are the populations that I kind of think about in terms of timing and when to kind of start. I wouldn't worry about it in your 20s and 30s in terms of that piece, prostate cancer. General prostate health, sure, but prostate cancer, it's not something I would stress about in my 20s and 30s and even early 40s. It'd be exceedingly rare to find prostate cancer. You find them rarely in the 40-year-old, 45-year-old, but tends to be a disease of between 55 to 70 is our kind of screening window.
I see a question here. The PSA is a prostate. What is the PSA? Something antigen. Yeah. Prostate.
I'm seeing
surface antigen.
Yeah. So PSA is prostate specific antigen. Okay.
Specific. Yeah, specific.
And it's a simple blood test, not invasive at all. It's a lot of primary doctors, a lot of patients don't even know that they've had one done. Put it that way. As primary doctors, oftentimes, to avoid this whole discussion we just had, will lump as a part of the general every 6 month or every year labs that you get when you see your primary doctor. So it's not invasive at all. It's a protein, actually. It has a role in life. It's a protein that the prostate is always making. And its role in our younger years is actually for reproduction. It goes into the ejaculate and it helps to liquefy it once it's in the female side of the reproductive tract, okay? And helps the sperm basically get out of the ejaculate fluid to swim to where they need to go. However, once you're kind of past that point of life, then it really serves no important role as the screening tool. The best way I kind of think about it is it's like a check engine light for your prostate. It's very non-specific in terms of, when it is a little bit elevated, we don't always know why that is. It can be elevated for a lot of different reasons here as well. You could have had your test taken the day after you had intercourse. That's going to make the PSA a little bit higher. You can have a low-grade bacterial infection or just some low-grade kind of chronic inflammation, and that is going to make that PSA test a little bit higher. The general number that we use on this test is somewhere between 3 to 4 is the kind of the value that you're looking for. You want to be below that. Getting above that, then at least, as a urologist, we'll usually see you. Your primary doctor will usually refer you over, and we'll start to have the discussion about what this could represent. My first rule of thumb is usually just to recheck it. So I tell guys, and I want guys to know, if you do have an elevated PSA that first go around, take it seriously. Get seen again by your primary doctor somewhat quickly, or get in with the urologist. But I'll usually repeat it to make sure that it is in fact elevated. And if it is, then we start to have a discussion about, okay, what could this represent? What kind of symptoms are you having? If somebody comes in and their PSA, let's say, is 6 or 7, which is a little bit elevated, but they say, man, just before I had that test, I started noticing I'm going to the bathroom like 20 times a day and it really burns, and I have a lot of low kind of crampy back pain. I'm a little bit concerned you might actually just have a prostate infection. So we'll treat it, see how you do, give it some time, and recheck the PSA, a month, 2 months down the road, and see if it comes down. But if it is elevated, that's when you go on to a discussion of a prostate biopsy.
Mm-hmm. Okay, thank you for that. That was very, very detailed. I appreciate you. Very complete. No, I really appreciate that, because I don't think people are having these conversations. I don't think people are knowing them. And I used to think PSA would start at age 65. So I was actually completely off. It's 55. And then there's a family history, it's 40s, or if you're having symptoms, it's whenever you're having symptoms, it's checked. So thank you for that. Now, do you know what's the most common cause of UTIs in men? And are UTIs common in men?
So in general, no, in general. But as urologists, we see it a lot in guys, right? Because, in the general population, if a guy has a UTI, most primary doctors know that's pretty abnormal. And so a lot of guys who are having UTIs, but in the general population, the short answer is no. But when a guy does get a UTI, it tends to be later on in life. Younger men are typically not getting urinary tract infections. There's kind of a dichotomy there, right? So younger guys tend to get more, STDs causing the urinary symptoms. Older guys tend to get more urinary tract infections, and that's exclusively representative of kind of the change in anatomy over time and the change in behavior over time, right? The prostate, again, to kind of circle back to the prostate, tends to be probably the leading culprit for why a guy is going to get a urinary tract infection. The prostate is the outlet to the bladder. And if it's getting large and obstructed, a guy may not be emptying as well. That urine then will stagnate in the bladder, and the urinary stream is a stream, right? It should be flowing all the time. When you get a little pond, you get that bacterial overgrowth, and that's when you get a urinary tract. So it tends to be as we kind of age and get a little bit more kind of prostatic growth, that's when you're starting to see more guys getting UTIs. Another reason might be, urinary or a urinary calculus, a kidney stone. If you've got a kidney stone obstructing the urinary tract, that too can cause that. But basically, in guys, it's an anatomic issue. If there's somewhere in the urinary tract where the urine is not coming out of the body, that's the typical reason why we'll see a UTI.
So in general, as men age, the prostate gets larger.
In general. I've had 90-year-olds that pee better than I do. But I've also seen guys who have been completely obstructed at age 40, 45. One of the most variable things I probably see in my practice is urinary symptoms, from the prostate. It's totally variable, and kind of take each patient, individually and assess them and look for, see if the prostate's the culprit.
Thank you for that. Thank you for that. You mentioned kidney stones. What's the most common cause of kidney stones?
Well,
And
here in America, again, I hate to beat a dead horse here, but here in America, it's our diet.
mm,
1 in 10, roughly, it's a little variable there too, but 1 in 10 Americans going to get a kidney stone. And if you're looking for a diet that, like, if you wanted to Google what is the most pro kidney stone diet in the world, it would be the Western diet. I mean, it is just chock full of the stuff that makes kidney stones.
mm.
But yeah, the Western diet is probably the biggest culprit.
Anything people can do? Any particular ones they should specifically avoid to reduce their chances?
Yeah,
Is it just like the carbs, or is it the fatty foods, the fried foods?
Yeah, it's a combination of it all. And really, the most common kidney stone you're going to see is a calcium oxalate kidney stone. So oxalate is the big problem there. We used to fixate on the calcium piece. So back in the day, urologists would tell patients who have kidney stones, don't drink any milk, don't eat any cheese, don't do any of that. It's all calcium. But I think as we've kind of learned more about the actual, pathophysiology of why we get kidney stones, it's probably more to do with the oxalate consumption that we have in our diet. What is oxalate? Oxalate is basically a breakdown product of protein. And this is protein that comes from pretty much any source. So to eliminate oxalate completely from one's diet is near impossible. However, I do usually find somebody has a culprit food or drink, let's say, that they consume a lot of that leads to kidney stones. For example, people will grab a handful of nuts, just nuts as they're working or, driving. I can't tell you how many times I've heard patients say when I'm treating them for kidney stones, yeah, as I'm driving, I'll just, pick up a handful of nuts and eat those, and I do that every day. I'm like, well, a lot of protein there, a lot of oxalate, that's probably one of your main risk factors for kidney stones. Leafy green vegetables, right? This is one of the other things that's kind of paradoxical. If you're eating a lot of salads trying to be healthy, you might actually put yourself at a bit of a kidney stone risk because like spinach and kale are just rich in oxalate.
Wow.
Kind of like how, urinary infections or cancers are a multifactorial problem, so are kidney stones. If you, go to a urology residency, a lot of lectures on kidney stones will have 2 columns, stone promoters and stone inhibitors, right? So there's a combination of these things floating around in our body. The kidneys have some natural, stone inhibitors that they produce. As we've evolved, kidney stones have actually always been a problem. And so, you got your stone promoters and stone inhibitors. There are a lot of stone inhibitors that you can consume as well, right? So my general counseling on kidney stones is to drink more water. If you think that you're drinking enough, drink more. Your urine needs to be crystal clear, and you should be telling me you're peeing all the time if you're a kidney stone former. And that might include getting up at nighttime to go pee, because I need you to drink 2 to 3 liters of water per day. You need to increase citric acid. So citrate is probably one of the most potent stone inhibitors that we have. And that's for a lot of reasons, a lot of chemistry, pH balance, and a lot of other reasons. But citric acid is actually pretty easy to get. You can get it in lemon juice, orange juice, lemonade. One kind of easy life hack is to get some Crystal Light and mix it with your water. There's a ton of citric acid in that. So boosting the citric acid is really helpful. Watching the salt intake, there's a lot of chemistry behind why that is, but decreasing the salt intake in one's diet in general can help to reduce the kidney stone risk. And I usually will counsel patients not to eliminate all their calcium, because if you eliminate all the calcium that you're consuming, if you think of a kidney stone as 2 pieces, a calcium piece and an oxalate, calcium oxalate, if you get rid of the calcium in your gut, you have all this oxalate freely floating in your gut, which gets absorbed, goes to the kidney, and can help to promote a kidney stone. So paradoxically, if you get rid of all your calcium, you're going to increase your risk of it.
More kidney stones.
Yeah. So that's general advice. There's more to that as well. Depends on kind of the chemistry of the urine. We'll often check that. Watching the animal protein, that's anything with the face. Okay, so chicken, pork, steak, whatever. If you're eating, heaping quantities of protein every day, you might be at a little bit of risk for kidney stones. But if you're hydrating well, it kind of washes all that out. So,
Mm-hmm. Oh, that's awesome. So, more water, drinking more water
yeah,
will, yeah. And then, like you said, I think everything boils down to lifestyle. So even for kidney stones, everything boils down to eating right, not eating in excess of one particular thing,
yeah,
not eating in excess of protein, in excess of veggies, in excess of carbs, just kind of balancing things out, that also applies to the testosterone. The part about prostate enlarging as people age, the main symptom people are going to first notice is the ability to pee, right? That'll be the first symptom they notice when the prostate begins to enlarge, right?
yeah, that's right. And that too is a quality of life thing. Just because you have a little bit of kind of slower stream, doesn't mean you have to have anything treated. If we'll check your PSA, typically do a rectal exam, feel for any lumps or bumps, on the prostate, make sure there's no abnormal exam findings. And if all that checks out and you're not bothered by, a little bit of a slower stream or, having to pee a little bit more often, getting up at night, one time, oftentimes we'll just let that go as long as possible, and I've got guys where I would be bothered if I was in their shoes, but they don't mind at all. So we just monitor to see if they get worse.
Wow, this has been awesome. I learned so much. Thank you.
Anytime.
Thank you. Anything else you want to add on? Anything I didn't cover?
No, in general, I think kind of some of the high points that we hit on today, but in my clinic, I'm always saying this because I get asked about, diet regarding stones, prostate, the cancers that I treat. Heart healthy is urology healthy. It's going to be kidneys. It's going to be good for your bladder. It's going to be good for your prostate. Every part, every organ that I treat, including the diseases like the kidney stones. Heart healthy is just going to be urology healthy. So despite me doing a lot of surgeries, despite me prescribing a lot of medications, a lot of the problems that you need to see a urologist for can be circumvented if you have a good high quality diet and lifestyle, which in the modern era is not easy to do. I mean, as docs, we're in a high stress environment all the time. I mean, we know firsthand how difficult that is. And that's probably why we see so much stuff that we see, is because it's hard to achieve that lifestyle that all these doctors talk about, right? Like, I mean, I'm a little hypocritical. It's hard for me to do that every day, but that's kind of what the goal is. And you might not achieve that every day, and that's okay. The goal is to try and get to, a healthier lifestyle, better diet when you can. There's going to be days you're taking the kids, to soccer practice and you're going to slam a quarter pounder with cheese. That happens, but the goal is to not do that every day.
Every day. Right.
But yeah, I don't have too much else to add. I would say, there's some cancer stuff that I see as well in my clinic, but I would tell you, know that urologists exist. We treat men and women, kids, adults, and we're pretty fun people. The nature of our job is to be pretty laid back with the subject matter that we see on a daily basis.
Right.
So if patients ever have questions or concerns on any front, get in and see a urologist. I'd say that we can offer a lot in terms of quality of life. Our passion, I think, for most general urologists is improving quality of life. And that's just kind of what we do.
Thank you so much, Dr. Sal. This has been an amazing session. I learned a lot. And I'll be sharing a lot of this with my guy friends, with my male friends.
Well, thanks for having me on. I'm super proud of you in this whole endeavor here.
Thank you.
Yeah, I love watching the other guests that you've had on. Of course, a lot of friends from med school. It's always good to see their faces and all that. So really proud of you, and anytime, always here to help.
Don't make me cry. I'm gonna start crying. Thank you, Sal. I really appreciate it.
All right. Bye.
My love to the kids.
See ya.
Bye.